We're going to move on to the diagnosis, analyzing cues, prioritize hypothesis portion of this lecture. This section can be a little difficult to understand at times because this is where we're taking all of that data from our patient and figuring out what's wrong with them. But we do it in a different way than a provider would, so let's get started. I'll be using both the nursing process terms and clinical judgment model terms for this section to make it easier for you to understand the flow. Just know that the clinical judgment model terms are the terms that we use on our exams and our care plans. For simplicity of the very long titles, I'm going to make the slide headers just say analyze and hypothesis from here on out in this PowerPoint section. I have the picture of the clinical judgment model for you again, and if you notice this section is in yellow because they're all the same step. This is where we figure out what's going on with our patient, what is their problem or diagnosis, what's wrong with them, what needs to be fixed. This step relies heavily on our ability to assess our patients because if we didn't assess accurately, we may think the issue is something different than what it really is. This is why I said in the last PowerPoint to ask questions if you're unsure of what you're finding in your assessment. I mentioned that assessment is the most important step of the nursing process because this is where we gather all of our data to determine the problem our patient is having. The picture on the right shows how we can use all of the assessment data to get to the nursing diagnosis or problem. We take all of that data and we use our critical thinking and clinical reasoning skills to analyze the data. We process that data in our minds, reflect upon it using knowledge we already have, past experiences. We ask other nurses or providers for help, and then we start to draw conclusions about what the problem might be. In the beginning of your nursing career, it might be very helpful to make a list of what you think the problems could be. Then analyze that list and remove anything that could be similar problems or diagnoses. Once you've limited your list to the actual problem, you want to find the actual name for the diagnoses. I said earlier that nursing diagnoses were not universally used and that NCSBN does not use them, but I also said this early in the program, we will be using actual nursing diagnoses and our nursing diagnoses book to help you through this process and make it easier. We call these official diagnoses NANDA after the North American Nursing Diagnosis Association. So if you hear us say NANDA instead of nursing diagnosis, that's why. Some problems our patients may have are risks. The patient might be at risk for an infection, but they don't actually have an infection yet. They might be at risk for falling, but they haven't fallen yet. That's okay. Risks are as important as a real diagnosis as well. And the last thing you need to do when coming up with the problem or diagnosis is look at what resources you have and what strengths the patient has. That was a lot of information very quickly, so we're going to break it into some smaller pieces for you. We have our data from our assessment. Now we need to analyze it. We need to look at all of it and see what is relevant and what is not. We need to look at normal findings also. Sometimes a patient can have many things wrong with them, but something we anticipate to be wrong is not. It's normal. This can be very useful information for us. I know it doesn't seem like it makes sense right now, but as you get into actual body systems and medical diagnoses starting in block 1 all the way to block 4, you will gain the knowledge to know what is normal and what is abnormal and what is anticipated for a disease process. Analyzing your data is giving you the cues you need to determine the problem. Once you have gone through all your cues, ask yourself, of these cues, what matters most? What cues matters and what cues do not? Then ask yourself, what do these cues mean? When you figure out what the cues mean, you are very close to determining the problem or the nursing diagnosis. You may hear people call the problem the priority problem or the priority or the nursing diagnoses. They are just different terms for the same thing. Just like using the clinical judgment terms, we will use priority problem or problem on exams, so make sure you know those terms. So what is a nursing diagnosis? Well, let's look at what it is not. It is not a medical diagnosis. Medical diagnoses identify and describe a disease like pneumonia, and it stays with the patient as long as the disease is present. Medical diagnoses are also treated within the provider's scope of medical practice. Medical diagnoses deal with the pathological changes in the body. In contrast, nursing diagnoses describe a patient's response to an illness or disease. Using pneumonia as a medical diagnosis, we see that our pneumonia patient is coughing and coughing and coughing so much that they're struggling to breathe and can't cough up all their secretions. Yes, the coughing is related to pneumonia, but what can a nurse do to help the coughing? The coughing is the problem right now, and if we as nurses can do something to help the coughing, the patient will be able to breathe better. Nursing diagnosis can also change day to day, depending on how the patient is doing or how well they are responding to the care being provided. So we did something to help the patients cough, and now they aren't coughing anymore. Well, the coughing is no longer the problem. Nursing diagnosis can be treated within our scope of practice, and sometimes we are focusing on problems that may have nothing to do with the patient's medical diagnoses. An example would be body image disturbance. I like to think of it as a patient with breast cancer who just had a mastectomy and is mentally dealing with the loss of their breast. Medically, the patient is fine, but mentally, the patient may be struggling at looking at themselves in the mirror. Nurses can help with that. And just remember, nursing diagnoses are not universally used everywhere. When we're determining what the patient's problem actually is, it may be hard to figure out what the priority is and what it's not. Patients never have just one problem. They can have many problems, and we look at them and try to figure out what the priority problem is for us. The first thing we need to do is to look at their problems and figure out what's going to kill them first. We start with the ABCs, airway, breathing, circulation, in that order. Is one of their problems affecting any of those? If their problem is one of those, then that's our priority because that's going to kill them first. If we don't have one of those issues, then we can start looking at Maslow. Do we have a physiological problem? Do we have a safety problem? We move up the pyramid until we figure out the problem. It can be hard to remember the periods, so I like to use the ABC-SDEF method. Airway, breathing, circulation, safety, discomfort, education, and feelings. If you use this acronym, you should be able to figure out the priority problem for your patient every time. There is an art to wording nursing diagnoses or problems. We call this a PES statement, problem, etiology, signs, and symptoms. The first thing we need to do is to start by writing out the name of the problem. This early in your program, I suggest you use the official NANDA names. Yes, I said those were not universally used, but they will greatly improve your ability to critically think through Block 1. Make sure you are choosing a nursing diagnosis that is focused on the current problem occurring to your patient or a potential physical or behavioral response to their health or illness. If it is a current problem, we call that an actual nursing diagnosis. If it's a potential issue, we call that a risk for nursing diagnosis. People can be at risk for infections or risk for falls, like I mentioned before. A few slides ago, I mentioned a patient with pneumonia who was coughing so much they could not breathe effectively. That is a problem currently occurring in the patient. So that would be an actual nursing problem needing an actual nursing diagnosis. I would write that pneumonia patient has a nursing diagnosis of ineffective airway clearance. The second part of the PES statement for nursing diagnosis is the etiology. This is where we write our suspected cause or the reason for the response or problem. We use our knowledge to make this inference to the cause of the problem. We write the etiology section with related to. For our poor pneumonia patient, I would write ineffective airway clearance related to excessive secretions. I would like to note that etiology is not the medical diagnosis. This is where we need to write in what's causing the actual problem. Our pneumonia patient is coughing so much because there's too much secretions to cough out. Yes, the pneumonia is causing the secretions, but we don't use medical diagnoses here. The last part of the PES statement for the nursing diagnosis is the signs and symptoms. This is where we write the cues we found during our assessment. We write as evidenced by and then list out the signs and symptoms. If our patient has an at-risk diagnosis, there is no S as the problem has not happened yet. Instead, there is an itemization of identified risk factors. For a pneumonia patient, we would write ineffective airway clearance related to excessive secretions as evidenced by nonstop coughing, thick green sputum, and decreasing oxygen saturations while coughing. Here's a cute little nursing diagnosis written correctly. The nursing diagnosis is excessive stress related to chronic exams secondary to school as manifested by uncontrolled crying, extreme exhaustion, and hysteria. Here are some more examples of correctly written PES statements for you to look over. Some issues we have with the nursing diagnoses or problems stem from our assessments and analysis. Sometimes we jump to a conclusion on what the problem is before we have fully assessed our patients. Remember that assessment is not just our physical assessment, it includes the chart as well. We need all of the data to form our diagnosis or problems. Sometimes we have all the data we need, but we analyze the data incorrectly and make the wrong diagnosis or problem. This is why we really need to use our resources when we're just starting our careers and when we're unsure. It's better to ask someone for help than to guess and miss a potential life-threatening problem. Another error we have is using a generic diagnosis or problem that is not specific to the patient. We'll talk more about being patient-specific in a future PowerPoint in the series, but our problems need to be patient-specific. Fall risk is an easy problem to use on everyone, but if we use it for everyone, we become complacent to the actual risk and we become almost immune to it. If we become immune to the real fall risks, then the people who are at risk fall because we stop looking for the real risks. Another error we have is the error of omission. The patient has a problem and we don't document it. If we don't document it, then no one knows it's a problem and no one will treat the problem. Then the problem gets worse and guess what happens? The patient has a big problem and could die. Electronic medical records are very helpful for documenting our problems. For starters, we can see what problems other nurses and healthcare team members determined the problem to be and what they are doing or suggest to do to help the problem. Remember that different healthcare team members have different focuses. Respiratory therapists and physical therapists are going to focus on different problems than we will, but we all work together to fix those problems because we are one interdisciplinary team. We document the new problems we found on our patient, or we update current problems already in the system that are still applicable. It's not uncommon for hospitalized patients to have 5 or more problems documented in the chart. We cannot overlook those problems because we found another problem. All of the problems need to be addressed. This is the end of part 3. Go ahead and move to part 4.